The Parkinson's podcast is brought to you by the Davis-Phinney Foundation and brings you the stories, wisdom, and expertise of people living with Parkinson's, care partners, and Parkinson's professionals. In this episode, we talk with Dr. Aaron Haug about what the terms on and off mean in the context of Parkinson's, what on-off fluctuations are, and how to work with your doctor to help manage them. Dr. Haug is a movement disorder specialist based in Englewood, Colorado. This episode is sponsored by Blue Rock Therapeutics.
Hi, Dr. Haug. Thanks for taking some time this morning to talk with me about on-off and the fluctuations that people with Parkinson's sometimes experience. This gets talked about quite a lot by people with Parkinson's when their medications start to work a little less effectively for them. Can you talk a little bit about just what does on-off mean? What is on, what is off in the context of Parkinson's?
Well, thank you for having me. I'm happy to be here to talk about this. This is a question that comes up all the time in clinic. And one of the first things that I'll say to people is that if they are asking me what on and off means, it may be that they're not experiencing it yet. There tends to be what they used to call a honeymoon period. I prefer to call it a smooth response period, where for the first years that a person is on medication, the medicine reduces symptoms, what you might call off symptoms, the inherent symptoms of Parkinson's, stiffness, slowness, often tremor. And the benefit of the medicine sometimes is a little transparent to people because a snapshot of before you start medicine compared to a snapshot of 6 or 12 months later, maybe there is clear improvement that I can document on examination and the family sees it, but it's been gradual from a person's experience and they may not really feel that the medicine is making as much difference as it is. And so in that context, people are often more on than they would be without medicine. They've had a reduction in their symptoms. But where on and off phenomenon really start to come into the conversation is as a person gets more years into their Parkinson's and they really start to feel, oh, I'm taking this dose of medicine, 30 to 60 minutes later, I'm feeling this turning on, kicking in phenomenon. I have less tremor. I feel more loose and coordinated in my movements. And then after some hours, 8, 6, 4, or fewer hours, oh, now I'm starting to feel that dose wear off. And some of those underlying symptoms of stiffness, slowness, and often tremor are coming back. And so on and off fluctuations are something that if what I just described doesn't resonate, then you may not be having them yet.
So one quick follow-up to what you just said. There's no rule about this, right? Like you could have a dose wear off after an hour or something. You know, it's not going to necessarily be 8, 6, 4, 2, whatever. It could be any range of time could be involved in this experience for people. Is that true?
Yeah, that's true. Some people, especially as they get more and more years into Parkinson's, may have sudden off phenomenon or even dose failures where, gosh, that 10 a.m. dose didn't seem like it ever kicked in. And so these on-off phenomenon are sometimes something that you can nicely map out on a 16-hour waking day, but other times are not.
Just to lay a sort of baseline here, when you talk about someone being off, and then that would mean that their symptoms are either returning or intensifying maybe, that's not just motor symptoms, or is it? Could it be non-motor symptoms?
It's a really good question. And the answer is yes, everything is fair game. Most obvious are often the motor fluctuations, where those motor symptoms come back as the dose wears off. But non-motor symptoms can also fluctuate. Some people feel more blue, down, or depressed as their medications wear off. And some of those other non-motor symptoms can also fluctuate. And so it can be quite variable from one person to another.
And you might not even have all motor symptoms and all non-motor symptoms become noticeable to you at the same time if you're going off or medication doses wearing off. Is that right?
Yeah, that's also true. So that you can just kind of partially wear off where maybe you still feel pretty fluid and coordinated, but the tremor comes back. And offs can also be of different depths or different severities. I'll kind of do these hand motions in clinic where I raise my hand up as the medication level goes up. I'm describing that pattern. And then I kind of lower my hand down in kind of a S-curve or roller coaster illustration. But some offs are deeper than others. It may be that a person is only partially wearing off or more completely wearing off.
I think so far you've said that on-off is about when medication is controlling symptoms well or not controlling symptoms as well. And you started to talk about fluctuations. When it starts to become unpredictable, what causes that? What's going on in the body? Is there some change from Parkinson's that's causing that?
Yeah, we partly understand this, but partly we don't. And our incomplete understanding of it can be frustrating for people and for their providers, because why might one person develop fluctuations within months of starting medicine, and other people might be on medicine for 5 or 10 years or more and not be experiencing fluctuations? And we don't fully know the answer to that question. But what we do think of as happening is that when a person is early in Parkinson's, their brain still has not all, but quite a few of its own dopamine-making cells. And not only do those cells make dopamine, but they can, to some extent, take in and harbor and buffer the outside source of dopamine, the levodopa that is administered through medications. And so when someone is early in Parkinson's, you're taking the medicine 2 or 3 times a day. You're not feeling that this dose or that dose is kicking in or wearing off, because the brain is taking that medicine in and kind of metering it out in a gradual fashion that makes it just work all day, and there aren't on-off fluctuations. And then as time goes along and the disease progresses and the brain has fewer and fewer of its own dopamine cells, there's less of this buffering phenomenon that occurs. And we know that the true pharmacological half-life of levodopa is just 90 minutes. And so as people lose more and more of this buffering ability as the disease progresses, people may start to feel their on and off fluctuations as frequently as that. And so it has more to do with the progression of the underlying disease than it does with medication. People often wonder, well, what if I wait on starting medicine? Can I put off the motor fluctuations? And the answer to that is nuanced, but it basically comes down to the current standard of care is to use medicine to improve quality of life. And if person X, starts their Parkinson's at age 60 and kind of tries to grit their teeth and make it to age 65, just toughing their symptoms out, versus they start that same person on medicine at 60 and get relief from some of their symptoms, that person may develop fluctuations at a similar point in time. Maybe you have 5 years of disease where you're not going to fluctuate as a significant troublesome issue, and whether you're on medicine or not may not change that timeline very much. The flip side of that is if a person never takes medicine for their symptoms, well, they're never going to experience on-off fluctuations. They'll just be off all the time.
And I suppose that in the same way that any 2 people might have different lengths of time, from time of diagnosis and time of starting their medication, those 2 people could have wildly different times with regards to when their on-off fluctuations begin, if they even ever do begin. Is it possible that somebody never has on-off fluctuations? Or is it, you live long enough with Parkinson's, everybody gets there?
Well, it's a little bit of both. Most people that are treated with medications eventually develop motor fluctuations, but you're right that the time to when that sets on varies quite a lot. Some people have more severe Parkinson's than others.
My next question was about how we learn about medications that we might take for Parkinson's as people living with Parkinson's. I didn't say, but I happen to live with Parkinson's myself. I haven't mentioned that on this podcast yet, but I do. And so I'm, when I'm thinking about medications, I sometimes look at the trial reports. I sometimes look at what the prescription info says. And these documents talk about what was learned in the trial process that generated the approval for these drugs to be used in treating Parkinson's. And sometimes I see reference to a drug that reduces off time by 1 length, and it increases on time by a different length. I find that a little confusing. I think so do people that write into the foundation with the questions about what they're hearing from their physicians. I'm wondering, can you talk about that a little bit? How can there be a reduction in off time that's different from the increase in on time? Wouldn't that be the same thing?
They are often similar, but there can be some nuance there. Sometimes they talk about reduction in off time and then increases in good on time without troublesome dyskinesia versus increases in on time with troublesome dyskinesia. there's this sweet spot where when the medicine level in your body is too low, you feel off. And if the medicine level in your body and your brain is too high, then you're more likely to have dyskinesias and side effects. And if we're in the Goldilocks zone, in between too much and too little, that's where we talk about good on time without troublesome dyskinesia. And so those studies are often breaking those fractionated times out between off, good on without troublesome dyskinesia, and on time with troublesome dyskinesia. And I suspect that if you add up both of those different types of on time, it pretty much equals the reduction in off time.
So I want to give a shout out to another video we have on our YouTube channel that features you. And you were talking in this video about the difference between tremor and dyskinesia. And I think what you just said draws that video to my mind, because I think sometimes it's hard for people to know if what they're experiencing is a tremor or dyskinesia at some points in their Parkinson's experience. So I think what you just said about on-off and the way that might be reported with regards to what you can expect from a medication, I think that points me back to that concept. Is that fair to say that I can have my tremor can be very well controlled by my medication, but it might actually contribute to dyskinesia, which is not, I'm not off, I'm on, but I'm having this, is it right to say that's a side effect? I guess so.
Yeah, that video, thank you for bringing that up. It's just a few minutes long. And if you look up Davis Phinney, Aaron Haug, tremor, dyskinesias, you'll find it. And you'll get to see some of these hand motions that I'm currently just trying to describe in words, and talks about how that Goldilocks zone of good on time gets smaller as people progress through their Parkinson's. And that's why we sometimes need to start to get more sophisticated in our treatment approaches.
Okay, so let's talk about what can people do about on-off fluctuations. What are the approaches somebody takes to address on time that's too brief or off time that's disruptive? What can people do?
So there's several different strategies, and it depends on identifying the pattern that a person is experiencing. So if someone comes in and says, oh, I feel like my meds are wearing off 4 or 5 hours after I take them, when my meds are working, I'm not really having side effects. They're just wearing off too early. Well, we've got several different options. One is to just increase the amount of medicine that a person is taking at a time. That might increase your side effects, nausea or dyskinesias, but by getting the peak higher, the tail of the medicine gets longer. And so that may help connect one dose to another and create a smoother effect throughout the day. A slightly more onerous approach, and one that we often use, is fractionation. And this is if a person comes in and says, oh, well, when my meds are on, I'm having a little bit of side effects, dyskinesias, and they're not lasting as long as I wish they would. Then we might take their medicine and fractionate it into more doses. An example would be if someone's taking 2 tablets of carbidopa-levodopa 3 times a day, and they're having peak side effects and early wearing off, then we might fractionate that into 1.5 tablets 4 times a day. So it's the same total amount, 6 pills per day, it's just spread out more evenly. Some people like just sticking with the medicine they know, and that's kind of the simplest way to do it, even though it's a bit of a pain. But then there are also other adjunctive medicines, other long-acting forms of oral levodopa, or other advanced treatments that provide a more continuous infusion of medicine or a more continuous treatment in the form of deep brain stimulation. So there's several different ways that it can be approached.
What about if on and off times are becoming difficult to predict? And I think you may have just answered that question with what you referred to with DBS and other treatments that are available. Is that true? Is that what we would do to manage difficult to predict on and off?
Yeah, so difficult to predict on and off is, again, something that might be more troublesome as a person gets 5 or 10 or more years into their disease. And sometimes these same strategies of fractionation or extended release formulations, even if we can't clearly put a finger on what the pattern is, and we can't draw out a nice graph of, well, here's my 8 a.m. dose kicking in and wearing off, here's my noon dose kicking in and wearing off. Sometimes those same strategies are helpful. And since they're kind of easier, we will typically do those first before we think about a continuous infusion therapy or deep brain stimulation therapy. But often those more advanced treatments do help with those unpredictable on-off fluctuations.
Okay, thanks for giving us some insight into a couple ways you can approach this this challenge if you're having it. You and I had a conversation a while back about whether you can compare medications on and off time performance in trials one-to-one. And anyway, when I asked you that question, you had something to say about that, which was that maybe we can't necessarily take what happens in a trial for one drug and compare it to what happens in a trial for another drug. Can you talk about why that might be the case, why we can't do that?
It's not a great idea to do that. And this is one of the things they teach us early on in medical training is don't try to take one package insert and compare it to a different one because the circumstances of the trial may have been different. Some of the really key differences between one Parkinson's trial and another was the average age of the patient population the same? Was the average duration of their disease the same? Some trials might have an average disease duration of 5 years, and a different trial might have an average disease duration of 10 years. And it's going to affect how they respond to whatever treatment is being introduced. And then probably the last very important variable to consider is how much off time was a person experiencing in their typical day. In some of these trials, people are not fluctuating yet. They don't even have significant off time. And other trials have looked at people that are in a more advanced stage of their disease and might be having 4 or 5 or 6 hours of troublesome off time per day. And to look at the bottom line of, well, this group had 1 hour of better on time, and this group had a experience of 3 hours of better on time. There's more room for improvement, and the patient populations are just different.
So as we close up this conversation for today, I wonder if you can just give a sense of if somebody's listening and they think they're experiencing on-off fluctuation, what's the first step? Should they come into their doctor with notes? Would you recommend that they try to get these charts together and say, I take a dose now and it starts working in an hour and it stops working in 3 hours? Or is it enough to just go into your doctor and say, these drugs aren't working well for me? How can people get the best care when it comes to managing their on-off fluctuations?
I think it's kind of a step 1A and a 1B. Putting some thought into it and observing whether there is a pattern for you as you are also waiting for that next appointment with your doctor. I think doing those two things in tandem, because what's going to happen at that appointment is the doctor or advanced practice provider is going to ask, well, is there a pattern? Do you notice that your meds kick in after 30 or 45 minutes? Do you feel that after your 8 a.m. dose is in and it's getting towards noon, are you feeling by 11 or 11:30 that it's wearing off? And so if there is a pattern like that, it behooves you to spend a few days looking for it and writing it down. Because if you crack it and figure out, oh, you know what, I'm getting 3 hours and 45 minutes of on time per dose, and you bring that into your provider and say that, they'll say, okay, well, great, I know where we're at now. And there are multiple moves that we can make to try to improve this.
So it sounds like your recommendation would be if you can find a pattern, that's probably helpful to bring to your appointment. In a way, it's sort of the more information you can provide, the better. Is that fair to say?
Yeah, for sure. Patients who come in and say, my meds aren't working very well, we then have a conversation about, well, what does that mean? Is there a pattern to it? Are you having side effects at the peak? Are you having wearing off at the trough? And how can we improve it?
Excellent. Okay, well, thanks for your time this morning, Dr. Haug. Is there anything else we didn't talk about with regards to on-off that you think we should have talked about?
On-off can be frustrating in two ways. One, people wonder if they're having it. And if you wonder that, then you may not be having it yet. So you can take some reassurance from that. And second is that if you are experiencing it, it can be a challenge to try to get as much good on time in the course of the day as possible. But the science is always moving forward, and we've got multiple treatment strategies that can be helpful.
Yeah, so I guess maybe that's a way to wrap this conversation from my perspective. I think I would just want to offer to the audience that, but what you just said about the different treatment options suggests that there's reason to hope that there is a path forward that can help you and that might work well for you. So maybe just don't give up hope. If the first thing you try doesn't solve this problem for you, there's probably something else you can do.
I think that's right. There's multiple tools in the toolbox, and just because the first one doesn't work doesn't mean that we don't have more things to try.
Well, thanks for taking some time this morning. I look forward to connecting again in the future, and I always appreciate your willingness to help us out and share some information with the Parkinson's community. Thanks for your generosity in that regard.
You're very welcome. Thank you, Chris.
Thank you for joining us for this episode of the Parkinson's Podcast. For more information about the Davis-Phinney Foundation and to learn about educational offerings and community events for people affected by Parkinson's, please visit davisfinneyfoundation.org or dpf.org. This content includes information, insights, and opinions from our Parkinson's community. The views expressed are those of individual participants and do not constitute medical advice. This content is not intended to substitute for the guidance, advice, or recommendations of your personal healthcare providers.